started. So I'd like to welcome everybody back to our grand rounds for September 23rd. And I'd like to introduce you all to Dr. Stefan Ongton, who is our faculty member hosting this week's rounds. Dr. Ongton did his medical training as well as a PhD at McGill University prior to joining us at the University of Toronto for his ophthalmology residency. And he subsequently went on to do a cornea and external diseases fellowship at Harvard. So he's got quite the pedigree, and he has since come on as a clinician scientist based out of Sunnybrook, as well as the Department of Ophthalmology. So really an accomplished clinician, but an accomplished scientist as well. And he's got two great residents with him today, Dr. Marko Popovic and Dr. Kirill Zaslavsky. So I'd like to hand it over to them.
Okay, great. Thank you very much, Amadeep. And yeah, I'll the rounds for today is really we're going to be presenting two cases that's going to highlight, I think, two emerging technologies and techniques in the field of cornea and maybe in ophthalmology. One which is currently being used now, which is DSO, and then the next one is, I think, is going to play a larger role in ophthalmology in the upcoming years, which is still in the research phase. So I thought it'd be interesting to present a case where we use some of this technology. So I'll let the residents talk to you about the cases, and we can have a little discussion at the end as well. So first, Marko is going to present.
All right, perfect. Well, thank you, Dr. Ongton and Dr. Rai, for the introduction and opportunity to present. I'll just load up my slides here. And so I'll be going over an update on Descemet Stripping Only for Fuchs endothelial corneal dystrophy. Before I begin, I really want to thank Dr. Ongton for his help and support in preparing this presentation. So I'll just start off with a poll question here. And for this one, there's really no right or wrong answer, more just to get a sense of where the audience is. So I'll read it out. What would be your management of a 60-year-old patient with visually significant Fuchs dystrophy, primarily affecting the central cornea? Would it be a DSEC, a DMEC, Descemet Stripping Only, or a PKP?
So we'll give this a few seconds to run here. All right, here you go, Marko.
All right, so most people answered DMEC, but though there were some that answered DSEC and Descemet Stripping Only. So interesting to see the perspectives of the audience for this. And so I'll move on to a second poll question here. And I'll read this one out as well. Which of the following is not a factor that mediates clearance after Descemet Stripping Only? Is it A, the Descemetorex's size, B, the use of a long-term topical corticosteroid, C, preoperative pachymetry, or D, the use of a Rho kinase inhibitor?
You're getting more of a mix here. So it's a good thing we're going to get this talk today.
All right, yeah, definitely a mix kind of answer choices all across the board, though the most common one tied with C is, which is the right answer, is the use of a long-term topical corticosteroid. And I'll go into the presentation as to why that is and some of the factors that mediate clearance in DSO. So the answer here is B. So I'll start off with a case of a 63-year-old gentleman with Fuchs dystrophy who's has visual symptoms, morning blurring, and photophobia in both eyes. Here are his visual acuity, manifest refraction, intraocular pressure, and central corneal thickness. And you can see on his exam here that he has central confluent guttae bordering about 3 millimeters centrally there, nicely seen on the retroillumination. With some evidence of 2+ nuclear sclerosis and trace cortical cataract as well. And so, you know, there are options in terms of the surgical management of this patient. You know, traditional options might include a DSEC or a DMEC, though in this case, when the guttae are more central, a DSO option is possible. And so then if you look at the patient's confocal microscopy, you see here centrally there's essentially no endothelial cells that are evident, though peripherally the cornea looks quite good. So an endothelial cell count of just over 2,000 cells per millimeter squared. And so in the end, a DSO, Descemet Stripping Only procedure was recommended for this patient. And for those that might be unfamiliar with this procedure, I have a surgical video just kind of showing this procedure. So first, 4 millimeter central markings are made, smaller than what you might be used to in the case of a DMEC or DSEC. The Descemet is then scored with a reverse Sinskey hook only about 2 clock hours, which is in contrast to DMEC, where you'd be scoring kind of 360 degrees. And I'll go into reasons why that is. Once that scoring is completed and the Descemet's tear is initiated, specific Descemet's MST forceps are then used to essentially peel and continue that Descemetorexis 360 degrees until its completion. And so this case was done under Helon OVD, and that Descemetorexis is made centrally and continuously. And the nice thing about DSO, of course, is that there's no need for a graft. Once the Descemetorexis is completed, that essentially concludes the procedure. And so here, OVD is being removed and the case is concluded. And so after the surgery, this is kind of a standard regimen of an antibiotic and steroid, though a steroid does not have to necessarily be used for the long term, given the absence of a graft. Now, topical hypertonic saline can be used in the postoperative period if there's significant corneal edema, and also a rho kinase inhibitor may be supplemented. And I'll go over the mechanisms and indications when you would consider a rho kinase inhibitor for DSO. And so, reviewing what just happened, there was a central Descemetorexis done without a graft. And what happens, the reason why this procedure is successful over the coming weeks and months is because what's hypothesized to be happening is a migration of those peripheral endothelial cells centrally to achieve corneal clearance. And you see here a couple months after the procedure, again, a confocal microscopy showing re-endothelialization of the central cornea. And so this is just to give you an overview of the patient's postoperative time course. What I'll note here is, early it takes some time for the cornea to clear, for that process of peripheral corneal cells migrating centrally to actually occur. And so corneal clearance is not typically achieved as early as you would expect with DMEC or DSEC, though by post-op month 1 and post-op month 2, you see nice corneal clearance and an excellent visual outcome. So taking a step back and looking at Fuchs endothelial corneal dystrophy, this is, of course, the most common condition affecting the corneal endothelium, in which symptoms might include blurry vision, photophobia, and glare. This is a genetically heterogeneous disorder. A transcription factor 4 repeat expansion is the most common genetic variant identified that's associated with this condition. And you have the formation of these profibrotic corneal guttae and apoptosis of endothelial cells. And now the condition begins centrally here, as you see on the photo, and then proceeds peripherally. And so severe cases in which there's both central and peripheral disease may not necessarily be good indications for considering a Descemet stripping only procedure. And so how does DSO fit within the current surgical armamentarium? We know that DSEC itself involves transplantation of the endothelium, the Descemet, in a thin layer of the posterior stroma. That's in contrast to a DMEC procedure in which only the Descemet and endothelium is transplanted. And in comparative studies looking at DSEC and DMEC, it was found that there's overall better visual outcome with DMEC, even though it might be a more technically challenging procedure to do, and a lower rate of rejection. So then the question was, is it possible to get away without having any graft at all to minimize the chances of rejection? And so that's really where DSO comes in, which, where you have that central descemetorexis and migration of peripheral cells. And so I'll go over, just out of interest, a few case reports that initiated this concept of DSO and got people thinking about this procedure. This was a case in 2012 of an 80-year-old female who underwent DMEC for Fuchs, unfortunately had a free-floating Descemet's roll in the AC just hours after the surgery. This was a patient with significant AMD and low visual potential. And in discussion with her surgeon, patient elected to just observe despite not having an attached graft. And, as you would expect, there was initial corneal edema for a few weeks. However, this resolved, and this was an interesting finding as to why this may have resolved. And the hypotheses were laid in this case as to potentially this migration of peripheral endothelial cells centrally to achieve corneal clearance. Here's another case report of a 34-year-old female with both polymorphous and Fuchs-like changes. This is a patient who had a DSEC procedure in the contralateral eye that failed, had another DSEC done as a repeat procedure, and then sections of that DSEC began to detach. And what the clinicians observed is that with time, all of those areas where the Descemet's had previously detached started to clear. And as the detachment started propagating more centrally, it would take a few weeks and each one of those sequential areas would continue to clear. And so they also hypothesized that there must be some type of re-endothelialization process happening here. And so for the other eye, they decided to try just doing a Descemet stripping procedure without any keratoplasty, and patient did very well by 6 months, achieved an excellent visual outcome. This was another case from the phaco literature where an 84-year-old female underwent phaco and had inadvertent viscodissection of the Descemet's, and an iatrogenic descemetorexis was unfortunately performed, and similar to the other cases, had initial corneal edema that cleared after a few months with an overall favorable visual outcome. And so that brings me then into the indications for DSO. When would you consider doing this procedure? And so I mentioned that, in Fuchs, it has to be early stage disease where the guttae are limited centrally. The peripheral cornea has to be clear without any evidence of edema or scarring or significant guttae peripherally. Patient obviously has to be symptomatic and a surgical candidate. And there has to be enough of a peripheral endothelial cell reserve. And you'll see different things quoted in the literature, but at least 1,000 cells per millimeter squared is the bare minimum for considering this procedure. A patient can be phakic or pseudophakic, and this procedure can be combined with phaco if needed. And so in the early clinical observations of DSO, there was unpredictability in the success of the procedure. There was certain patients who were clearing and others who had persistent edema. And the question was why? What were some of those factors that mediated corneal clearance for this procedure? And one of the most important that was recognized is the descemetorexis size. And so I mentioned this in the surgical video that the descemetorexis is only 4 millimeters. And so that's smaller than what you might be used to, for example, in the case of DMEC. And so the idea here is that when you perform a descemetorexis of only 4 millimeters, you're really taking out, in a healthy cornea, you're really taking out only 10% of the corneal endothelial cells, allowing for a significant peripheral migration of endothelial cells centrally. And if you take a larger graft, like for example, an 8.5, or rather a larger descemetorexis, an 8.5 millimeter descemetorexis, you're taking nearly half of the corneal endothelial cells in a healthy case. And so with a smaller amount of cells taken in the descemetorexis, you have a higher chance of improved visual acuity, and corneal clearance. Second factor that was recognized relates to the surgical technique. And so I mentioned, unlike in a DMEC, in which you would score 360 degrees around with the reverse Sinski, in this case, with a DSO, you only want to score a limited area, about 2 clock hours. And the idea here is that if 360 degrees is scored, you can definitely develop stromal scarring and irregularities, which prevent the migration of peripheral endothelial cells centrally, and that inhibits the chance of achieving clearance. Also, preoperative pachymetry has been recognized as a factor that mediates clearing with DSO, specifically those who have thicker corneas preoperatively tend to have a lower chance of successful clearance. And I touched upon this briefly earlier, but the role of Rho kinase or ROCK inhibitors in DSO. And so ROCK inhibitors are known to us from the glaucoma literature. Recently had an FDA approval for glaucoma, where in that case they prevent fibrosis along the trabecular meshwork. In the case of DSO, they are a pro-proliferative agent. They inhibit apoptosis and increase proliferation of endothelial cells and promote the migration of those peripheral cells centrally. And so ROCK inhibitors can be used either as a salvage agent or in routine cases of DSO. And there's actually a phase 2 RCT now in DSO, specifically looking at the role of ROCK inhibitors in Fuchs patients. I next want to comment on a meta-analysis that was done here locally in Toronto. I was privileged to be a part of this analysis, and I want to recognize some of the staff on this paper, Dr. Ongton, Dr. Chen, and Dr. Slomovic, and some of the other team members here for leading this. We basically looked at all DSO cases in the literature, and we performed an individual patient level meta-analysis here. Because of the novelty of this technique, we only were able to include 9 studies dealing with just over 60 or dealing with 68 cases with a mean follow-up of about 12 months. Overall outcomes were excellent, with corneal clearance being achieved in 85% of the patient sample. The final best corrected visual acuity improved from an average of about 20/50 to 20/30 by final follow-up at 12 months. There was improvement in BCVA in 90% of eyes. And we found that in cases that had surgery with a ROCK inhibitor, the time to the corneal clearance was shorter. On average, we found that the time to clearance was about 5 weeks for those who had a ROCK inhibitor, compared to about 10 weeks for those who did not have a ROCK inhibitor after surgery. The mean central endothelial cell count was also higher in the ROCK inhibitor group at final follow-up. And so when looking at the predictive factors of success at the level of a meta-analysis, we found, similar to what I described earlier, 4 millimeter decimeter axis size, a clear peripheral endothelium with no clinical sequelae of decompensation or guttae, and a low central corneal thickness as predictive factors for success. And based on these clinical observations and based on the literature that we surveyed, we designed an algorithm, a decision tree, for those who are new to DSO and contemplating integrating this procedure into their surgical armamentarium, to give them a sense of when to use the procedure. And so I'll just go into this algorithm in a little bit of detail here, starting with those individuals who can be considered candidates for DSO. And so, as I said earlier, for DSO, you need to have patients who have relatively more mild disease. Fuchs can be graded on this Crackmore scale, and I've provided the grades here for your reference. But once you start entering into a significant amount of confluent central guttae over 4 or 5 millimeters, that's really where DSO starts to become contraindicated, or in cases where there are where there's evidence of stromal or epithelial edema. Again, we want the guttae to be localized centrally. You would expect a low to absent central cell count, though a reasonable cell count peripherally, and you want the periphery to be clear in order to have the highest chance of success with this procedure. If all of that is true, you also want to observe for any evidence of corneal decompensation or central corneal scarring, because those may inhibit the chances of success with this procedure. So if there's no decompensation and no scarring, DSO can be considered. The next step is really to evaluate the patient's cataract and to see whether it's visually significant, to consider doing a phaco DSO versus a DSO alone. And so the other side of the algorithm is essentially the reverse of what I just mentioned. So, if the guttae if there's a significant amount of guttae peripherally, if the periphery is not clear, if there's evidence of corneal decompensation or scarring, those would be factors that would sway you away from considering DSO. And then when deciding what, if you choose to go ahead with DMEC, for example, in those cases, deciding to go ahead with either a phaco DMEC or a DMEC alone. So I'll just conclude with the advantages and limitations of this novel surgical procedure. Descemet stripping only has a significant advantage in that it does not require donor tissue, and for that reason cannot induce any rejection. The nice thing about it is that even if, after a few months, their corneal clearance still has not been achieved, an endothelial keratoplasty approach can be considered. Because there's no graft that's being implemented, there's no need for a long-term topical corticosteroid. And so that's why that answer choice at the beginning of the presentation was the incorrect one. The limitations of this procedure is that you have to be careful and you have to be judicious about case selection. It's important to consider DSO for individuals with central disease where the periphery is clear and a reasonable endothelial cell count peripherally. There are complications of this procedure, as we know, either a decentered descemetorexis or a longer time to visual recovery relative to what you would expect for DMEC or DSEC. And overall, based on our meta-analysis, you can appreciate that there are limited long-term and well-designed studies in this setting. Most studies are really just case series at this point with short-term follow-up, and so further well-designed studies are needed in DSO. So I really wanted to thank everyone for their time and attention today, and I'll turn it back over to the panel.
That was excellent, Marco. Thank you for that overview. I do have a question for you guys. In terms of how long do we expect endothelial migration to persist following this procedure? Like, at what point is the patient, at their ultimate results?
Yeah, so I mean, from the literature surveyed, it does vary. I mean, at minimum a few weeks is what you would consider. But you saw some of these case reports where it may have even taken a couple of months for the full process to happen and for them to achieve their final visual outcome. Dr. Ongton, I don't know what your clinical experience has been.
I think for myself, and also speaking to Dr. Maloney as well, I think I have a kind of a 3-month window where I'm kind of giving them time to really show progress that their corneal edema is clearing and the endothelial cells are regenerating, or I would say migrating, because one of the potential sequelae of waiting too long with prolonged edema is you can get subepithelial fibrosis, and that can in the end limit the best corrected visual acuity. So it's kind of finding that balance of giving the endothelial cells a shot at re-endothelializing the defect, but you don't want to wait too long, because then you can even if you do the DMEC afterwards and you get rid of the edema, they could still have the subepithelial fibrosis, which can ultimately limit their best potential vision. So I give them about 3 months. If they really haven't shown any inkling that they're actually like detergesting their cornea, then the next step is a DMEC. And I counsel all the patients, about this, that there's no guarantee that will work, and there's always, we can always rescue it with a DMEC. I don't know if Dr. Slomovic here has any further insight to provide. I'm sure he does.
So I agree with everything you've said, Stefan. The only addition I'd like to make is that Greg Maloney showed that if he's rescued some DSOs that were not clearing with the use of ROCK inhibitor. So we always use ROCK inhibitor. The problem is it's not available in Canada. So we've had patients get it directly from Japan, and we give them the address and everything else, and they get it. It's not that expensive. It's reasonably priced, and it's not that difficult to get. The other interesting corollary of what's been said today is I know a few people are starting to use ROCK inhibitors for pseudophakic corneal edema, and in my very limited experience, I've not been overwhelmed by it. I've not, the results have not been great. However, by the time I get to see them, they're usually diffuse corneal edema. There was a paper that was just presented at ESCRS last week showing the rescue effect of ROCK inhibitor where there was only partial corneal edema, which makes sense because, it much in the same way as a DSO, you're recruiting the peripheral healthy cells to come in and repopulate the damaged central endothelial cells. So I think I would not do a DSO without a ROCK inhibitor.
Yeah, I agree on that. Yeah, all my DSOs, I put them immediately on a ROCK inhibitor. And I think the other key thing is with patient selection and as well, and choosing good candidates that are that really have central guttae and are quite motivated, and put them on the ROCK inhibitor. I've had quite good success since implementing the technique back here, since coming back. And I agree also in the terms of using ROCK inhibitors in the context of PBK, especially diffuse PBK. I think it's a different process where with Fuchs, where in Fuchs, especially those that are early on have this healthy peripheral endothelium that we're kind of relying on to stimulate and to repopulate the central area, whereas patients with PBK tend to have more diffuse cellular loss of those endothelial cells. So to me, doesn't make as much sense, unless you have some sort of reserve that you're trying to stimulate to kind of spread. But it only comes down to like a mathematical equation of, how much can a cell spread over a certain surface area. And if you just don't have the reserve, that it's like, it just won't, I just don't think it's going to be successful in those cases.
I was just going to make a comment that, a ROCK inhibitor really matters in these cases. When we looked at the literature, the corneal clearance in the cases we saw in our meta-analysis was about 75% cleared without the use of ROCK inhibitor, and it was well over 90% that cleared with the use of a ROCK inhibitor. So significant difference just with the use of the agent.
Now, maybe you mentioned this, Marco, and I might have missed it. How long are patients on the ROCK inhibitors? Because Dr. Burt has an interesting point in the chat here that the ROCK inhibitors were initially developed for glaucoma, but some patients have very red eyes as a side effect. So is this a short-term intervention, long-term?
So yeah, I mean, there are differences in the exact protocols that are used between studies. Typically, what we're seeing is use of the ROCK inhibitor for a few weeks, either anywhere from 4 to 6 times a day is what we've seen. But there is some level of variation depending on the study.
Amandeep, you're absolutely right. There's a lot more redness in patients using the. Is it Ropressa, the one that's been approved for glaucoma? Whatever.
Yeah,
it really causes a lot of red eye. I have not seen that to be a major factor with the Glanatec that we're getting from Japan. We haven't seen the same kind of toxicity with Glanatec. You bring up an excellent point there.
Yeah, just to follow up on that. Yeah, I mean, in terms of my protocol, I put them on for the first week about every 2 hours. Then I taper them down to about QID 4 times a day. And it kind of depends on how they respond. If they're clearing very quickly, then I try to taper them down fairly quickly as well. But if there's still edema, I tend to kind of keep it on and maybe taper it down as they clear a little bit. So there's, they're usually on it for a few months, I think, in my cases.
Similarly with me, Stefan, the interesting thing is I've had a couple of patients where I stopped the ROCK inhibitor and they've gotten edema and they've noticed a change in their vision, put them back, and they actually one just went back on herself, and
Right.
I put another one back, and it seems to have cleared it.
Yeah, I've had similar experiences as well.
So typically I keep them for about 3 months, 2-3 months on the ROCK inhibitor, but sometimes I've extended that depending on how the cornea responds.
Mm-hmm. One last point I'll just make, and then maybe we can switch gears a little bit to like Carol, just for the sake of time. But I do think there is a role for just in corneal edema for topical steroids. Not necessarily, like in addition to their anti-inflammatory effect. It's been shown, at least in vitro, that it can actually upregulate the sodium potassium ATPases. So in theory, it could drive further expression of these pumps that help deswell the cornea. So in a lot of these cases, I think there is a role for steroids specifically for that reason, not necessarily for their their immunosuppressive effect that we use it for, in patients that have grafts. But I think in to try to stimulate some of those sodium potassium ATPase pumps. Okay, great. So we're going to switch gears a little bit. I think thank you very much, Marco. That was great and well presented. So next, I'm going to introduce Kirill, who's going to be talking about an interesting case and kind of an emerging technology that's not only relevant, I think, to the field of cornea and specifically maybe infectious keratitis, but I think has broader applications to the field of ophthalmology. It's still in the research phase, but I thought it'd be interesting to kind of present it to the group here.
Thank you very much, Dr. Ongton. And thank you for the privilege of presenting this case. It's called Bird's Eye View, and this is the case Dr. Ongton saw during this fellowship. So we're starting off with an 18-year-old college student who really likes animals. So she is a veterinary student. She's a veterinary employee. She has tattoos of animals on her body. And so she's referred for an atypical microbial keratitis in the left eye. Her symptoms started about a month ago, and they're classic pink eye symptoms. So watering, redness, irritation, and it coincided with exposure to parakeet debris to her face. So initially she was treated with topical ofloxacin, systemic antibiotics such as erythromycin and doxycycline, although turned out to be intolerant, and then changed to azithromycin. There's a conjunctival swab done by the referring ophthalmologist. Viral culture was negative, mycoplasma and ureaplasma cultures were also negative, and chlamydia trichomoniasis culture was likewise negative. So not very revealing. In the meantime, after switching to azithromycin, she presented to the emergency department with shortness of breath. Chest X-ray was normal, and she was diagnosed with parrot fever. So more on that in a little bit. In follow-up with the referring ophthalmologist, she was noted to have new corneal lesions in the left eye. She was started on Pred Forte 4 times a day, but when they attempted to wean her down to twice a day, she experienced worsening symptoms. So blurry vision, some pain, not much photophobia. So they increased Pred Forte to 3 times a day and referred her for a cornea assessment. And more history was taken at that assessment. So turns out she was a contact lens wearer since age 14, currently using daily disposable contact lenses, but actually she only wore them 3 weeks before exposure most recently. She's otherwise healthy, and the only other medication is a birth control pill. On examination, she does have reduced visual acuity, maybe slightly elevated intraocular pressure in the left eye, and otherwise an unremarkable exam. On a slit lamp exam, we note that there's these small punctate opacities on the cornea. When you do an optical section, you can tell that these opacities are localized to the epithelial component, to the epithelial layer. And you can tell with fluorescein that these punctate epithelial opacities are staying positively with fluorescein. On lid aversion, you note that she has papillary injection, as well as some follicles in the upper tarsal conjunctiva, and similar findings in the lower papillary conjunctiva. So, in summary, we have papillary reaction and follicular reaction in the tarsal conjunctiva. We have a mild conjunctival injection without discharge. We have these punctate epithelial opacities in the lower 2/3 of the cornea that's stained with fluorescein, but an otherwise normal exam. So in summary, we have an 18-year-old healthy female with unilateral chronic follicular keratitis conjunctivitis. So my first question to you is, what do you think is the cause of her symptoms? A, viral infection, B, fungal infection, C, bacteria, D, parasite, or an autoimmune disease?
Interesting case, Kirill. We'll let this run for a few seconds.
Sure.
I'm seeing a bit of a split here. So here you go. Here's your results.
Okay, good. So let's see what the case reveals. So first, let's just step back and look at the differential diagnosis of chronic follicular keratitis conjunctivitis. Now, infectious causes are up at the top, with adenovirus being probably the most common one you'll encounter, but also HSV can cause this, molluscum can cause this, and some atypical microbes can cause this. Of course, medications, as we know, can also trigger this. Probably the most common one is brimonidine. But we also have in this patient a history of exposure to bird debris. And one pathogen that is common to birds that can be passed through bird debris to humans is Chlamydia psittaci, and it causes something called psittacosis, which is parrot fever. So what are the next steps? Well, one is we can look at the cornea with confocal microscopy, as well as do some conjunctival swabs for direct identification with PCR. So what does this in vivo confocal microscopy show? And just as a reminder, confocal microscopy here allows us to really look at specific depths in the tissue without signal from above or below interfering with the image. So what we're seeing here is these round and double-walled profiles in superficial epithelial debris. Now, these are suggestive of atypical microbe. Okay, so this is promising. Maybe this is C. psittaci. And so we have chronic follicular inclusion keratitis conjunctivitis with a risk for Chlamydia psittaci. So the plan is to continue on the pred forte, consider conjunctival swab for direct identification with PCR, and consider further systemic treatment, say with azithromycin and doxycycline, although we know that she is previously intolerant, versus topical treatment. So because her exam was unchanged, what was done is she was put on topical azithromycin in lieu of systemic treatment, and pred forte was changed to Lotamax CAD for 2 days. Now, conjunctival swabs were collected and were sent to CDC for speciation of Chlamydia psittaci. She also had blood work done for Chlamydia psittaci serology, and at this time, a sample of conjunctival swab was sent to UCSF for metagenomic deep sequencing. So The workup for chlamydia psittaci was unfortunately unrevealing. So it was chlamydia pneumonia, chlamydia psittaci were not detected in the conjunctival swabs. Blood work for chlamydia psittaci serology was likewise negative. So this wasn't, so we're not dealing with chlamydia psittaci. So what are we dealing with? So metagenomic deep sequencing results at this time were pending. So perhaps before looking at the results, I'm going to briefly talk about what is metagenomic deep sequencing. So metagenomics deals with the detection of all genomes in a sample. And this came from, this came from attempts to understand, what is the total microbial community in a specific sample, for example, in soil, in the gut, etc. Deep sequencing refers to the massively parallel sequencing that has been, that can provide basically an unbiased way to detect all the genomes, and this way give an estimate of what actually is contained in the sample that you're sequencing. How does it compare to standard clinical testing? So standard clinical testing, the method is typically PCR of extracted DNA, and its targets are limited. You have to specify what you actually are interested in testing for. Typically, the most common samples you would send are for viruses, HSV, USV, and CMV, and toxoplasma. Now, metagenomic sequencing is massively parallel sequencing of DNA or complementary DNA from RNA. So you're not limited to just organisms that have DNA. You can actually detect RNA viruses such as rubella. And because of the way it works, the amount of targets is essentially unlimited, and it is a relatively unbiased approach to detect them. So how does it work? So you can take an ocular surface swab, you extract your DNA or extract the RNA and then make cDNA, and then you make what's called a sequencing library. So all of this DNA and complementary DNA what you have is sheared down to approximately 200 to 300 base pair fragments. Little adapters are ligated at each end, and then they are run through a sequencer. As controls, you can use water or swabs in the contralateral eye. So once you have sequenced, what you end up what you end up with are these lots of tiny little reads that are then aligned to a genome. So once they're aligned to a genome, you can begin to reconstruct what they came from, what genes they map to, and because we're interested in detecting pathogens, what we do in this case is we remove all reads that map to the human genome, and then we keep all the reads that map to pathogen genomes. But even with this information, we still need to do a little bit of work to determine what is actually significant. So how do we call what is the significant pathogen here? And we derive a measure called reads per million base pairs. This is basically if we have lots of reads, for example, in this case, mapping to the Pseudomonas aeruginosa genome relative to, say, other genomes, then we can confidently say that there's a lot of Pseudomonas aeruginosa genomes present in the sample that we've sequenced. So what do we find in our case of the 18-year-old female with chronic unilateral follicular conjunctivitis? So here on the bottom, you see genome of Encephalozone helen, which is a microsporidium. And you can see that there's quite a bit of reads that are mapping to various portions of its rRNA. And when we look at the reads per million base pairs, we can see that it's actually significantly elevated in the eye that's affected relative to the contralateral eye. So Encephalozone helen is identified then as the pathogen Is Microsperidia. Then results were validated with pathogen-directed PCR, and treatment with systemic agents topical fumagillin was considered, but as this was a standard approach. But because the patient was doing okay and reduced topical steroids and erythromycin, we didn't go that route. Next, we sought to confirm this, the detection of encephalitis in Helm at a different lab with a different, with PCR as well. And so this confirmed at CDC. So now we have a dual molecular diagnosis with two techniques, metagenomic deep sequencing and PCR at two independent labs. A month later, the patient is doing better. She has resolved papillary and follicular conjunctivitis. She has two residual opacities without staining. So this is a comparison of how she presented on the left and how she's doing now. You can see that most of the fluorescein positive punctate epithelial opacities have resolved. And you can see that the tarsal conjunctiva no longer has the follicular or papillary reaction. Similarly, the in vivo confocal microscopy shows an absence of these double-walled profiles in superficial layers. So what's happened? So probably here the course of topical azithromycin has been therapeutic, although this hasn't really been something that's established in the literature. So discussion was to whether observe or treat with topical voriconazole for 3 weeks, and patient opted for topical voriconazole. 3 months later, vision was 20/20, back to baseline as reported by the patient. And on exam, we noted epithelial, nummular, and focal infiltrates without neovascularization or C-reaction, kind of similar to what you see after EKC. So here you can see them up close, and you can see the subepithelial opacities. So what is microsporidia? Microsporidia are a diverse group of obligate spore-forming intracellular protozoan parasites that are closely related to fungi. 2 life stages, proliferative and spore-forming. And spores are really the infective form. They're highly resistant to adverse environmental conditions. Now, many domestic and wild animals may be naturally infected with various microsporidia, and birds, especially citizens such as parrots and parakeets, can be reservoirs of this parasite. What does it cause? The symptoms are redness, irritation, watering, eye pain, lid swelling, foreign body sensations, essentially the symptoms that our patient presented with, and symptoms that could very well be mistaken for adenoviral conjunctivitis. May present with superficial punctate epithelial keratopathy, and maybe involvement of the conjunctiva as well as a deeper stroma. About approximately 5% of patients with conjunctivitis have microsporidia in South India. It's typically unilateral, and there's no predisposing risk factor identified in 77 to 8% of cases. Typically, it performs with these epithelial lesions that stain positively with fluorescein, as seen in our case, and it can be they can present in various different configurations. Risk factors for infection with microsporidia are immune compromise, topical steroid use, contact lens wear, exposure to soil or mud, as well as contact with infected water sources. As mentioned, it can be often misdiagnosed as adenoviral keratoconjunctivitis and is frequently underreported in the literature. Although early reports of microsporidosis were in immune compromised individuals, and there are increasing reports in healthy immune competent individuals, as seen in our case. Treatment, you have many options for topical treatment, most of them antifungals, so voriconazole, flugelin, as well as topical antibiotics such as ciprofloxacin, moxifloxacin, PHP, as well as some systemic options, and you can also continue to debride the corneal epithelium. Most of the time, most patients have a complete resolution without sequelae, although persistent superficial punctate keratopathy can be present, as well as subepithelial nummular keratitis and persistent conjunctivitis are all still possible. So we would not be able to diagnose microsporidia in this cases without metagenomic deep sequencing, which is an unbiased approach that interrogates all the genomes in a clinical sample, and it can enhance detection of common and unusual pathogens. For example, it can detect RNA viruses, as mentioned previously. And this contrasts with the gold standard approach of corneal cultures, which currently have a sensitivity of approximately 60%. So in 2019, the UCSF Proctor Group published a paper showing proof of concept of using metagenomics deep sequencing to diagnose external infections. And the advantages of MDS in this study was an extremely shortened time from sample to diagnosis, whereas with standard laboratory clinical techniques, the mean time from disease to diagnosis was 37 days, with MDS was 5 to 7 days. So it's a promising diagnostic technique, but there's still certain challenges. It's still quite costly. Cost can range from about $300 to $1,000 per patient. You still need to confirm diagnostic results with current gold standard methods because it's still in the research phase. And sometimes it can be difficult to determine if the commensal organisms are pathogenic in a clinical context. So although this may be a drawback, that is also, it also affects standard laboratory techniques. So while we've shown that MDS can be useful for diagnosing external ocular disease, the same group from UCSF Proctor has also shown that it can be very useful for diagnosis of intraocular infections. So this is a study that looks at vitreous samples that were previously validated by pathogen-directed PCR. Now, 27 out of 31 previously validated samples were also detected by DNA sequencing in this case, and 8 of 36 of previously negative samples were newly detected by DNA seq, so new diagnoses. And in addition, by having sequence information, you can actually look at whether the genes that you are detecting that are specific to the organism that is thought to be pathogenic confer resistance to treatment. So in the case of CMV, 3 out of 7 cases here were predicted to be resistant to ganciclovir or valganciclovir. We can also apply this to uveitis, or uveitis was previously thought to be idiopathic. So this is a case series of 6 subjects where a mix of aqueous and vitreous samples was diagnosed. And the note here is patient 6, where rubella was eventually discovered as driving this chronic bilateral anterior and intermediate uveitis. In 2021, the same group also compared metagenomic deep sequencing versus standard clinical practice in predominantly aqueous samples. So they had 41 samples total. And here they use standard PCR clinical tests, so looking for our HSV, VZV, CMV, and maybe toxoplasma. And initially, in 41 samples, the PCR was positive in 12. RNA sequencing was initially positive in 16, two of which were later confirmed with pathogen-directed PCR. The 4 initially missed by PCR were toxoplasma and CMV, whereas rubella and pythomyces were not detected by pathogen-directed PCR. And what you see here is that all of the samples that are detected with pathogen-directed PCR come up positive on the RNA sequencing, but 2 of the samples that are positive with RNA sequencing, pathogen-directed PCR could not detect. In addition, if you're looking at intraocular lymphoma, what you can do is you can identify infections that can either drive the development of lymphoma, or you can sequence the lymphoma directly and look at mutations in lymphoma driver genes. So for example, on the left here, you see data from a patient with lymphoma that was positive for both Epstein-Barr virus and HHV8. And on the right-hand side, you see patient with lymphoma that had a unique mutation in MYD88 gene, which is known to drive lymphoma. So the applications of MDS really go beyond just identifying external disease infections. They can help identify pathogens responsible for intraocular infections, those that drive uveitis, as well as those that can drive lymphoma. So in summary, we presented a rare case of avian-acquired microsporidia keratoconjunctivitis in an immune-competent adult that was identified with dual molecular diagnosis with metagenomic sequencing and PCR without standard corneal cultures. And this was after an extensive work of Chlamydia psittaci, which is thought to be the most likely organism, was proved fruitless. We've reviewed what is the differential diagnosis of unilateral chronic follicular conjunctivitis, so mostly infectious causes, as well as medications. And we've talked a little bit about metagenomic deep sequencing, which is now an emerging, promising technology for pathogen detection. However, because no randomized controlled clinical trials between MDS and standard clinical testing have been conducted yet, it is difficult to judge whether it is a technique that currently has clinical benefit for patients. So thank you for being with us today and listening to this presentation. And some of the acknowledgements here go towards the collaborators that contributed to this work, and Dr. Ongton, supervisor at MEI, Deborah Jacobs. Thank you.
All right, thank you very much, Karel, for that presentation and highlighting MDS as a kind of an emerging technology. I just wanted, I think a few comments about this case. I think MDS is really. I wanted to present this case. It was a case I saw in my fellowship that, I think it highlights certain things about us as clinicians, is that sometimes we get anchored in a certain diagnosis based on something about the clinical history or something about an appearance, and you can kind of get stuck in a sense in terms of a diagnosis. And I think this was a good example of having MDS, which is kind of a really unbiased technology that can really help with diagnoses in these challenging cases. And certainly we were maybe it was a red herring, or maybe it was not, the fact that she was given this tentative diagnosis of parrot fever, based on her exposure to bird debris, kind of led us to that diagnosis of Chlamydia psittaci. We thought we were being pretty smart, because I've never seen a case of that, and which led us down that road. But then when everything came back negative, we were a little bit we're I guess a little bit surprised, because we were pretty confident in our diagnosis, and then MDS really revealed to us the true diagnosis. So I really think that there's a place for this sort of technology. It's just about how it's going to integrate, especially in Canada, within our current standard of care, and certainly there are some costs and implementation kind of obstacles. But thank you, Karel, for highlighting that, and happy to answer any other questions. I know we're kind of near the end of the rounds, but
Karel and Stefan, that was a great case, great presentation, and really interesting technology. I mean, you demonstrated that there was a big difference between the right and left eyes in the microsporidia that was detected by MDS. But what happens when you're dealing with flora or microbes that can be normal flora of the lid? Do you see a much greater quantity detected as far as the DNA load, or how do you read those?
So if in the methods sections of those papers, where they actually discuss how they actually filter down to what is the pathogen that's responsible, that they think is responsible. So there's first, as I mentioned, they filter out all of the reads that map to the human genome, and then they cross-reference the remaining reads to pathogen database. Some are known human pathogens, and some are actually known commensal flora. And so you actually subtract those reads that map to the commensal flora, and then what remains are just the ones that map to those that are known human pathogens. So in a way, you are maybe likely to miss anything that may be caused by, an organism that is classically considered to be part of commensal flora.
Yeah, a follow-up. I mean, that's certainly one of the challenges, in using this technology, is because it, it can identify, but one of the advantages is that there's a quantitative component to it. It's just a matter of finding what's that threshold of what's pathogenic versus what's, kind of just commensal flora. So I think that's certainly one of the challenges of this and limitations of this technology.
Excellent. Thank you, Stefan and Kirill and Marco, for some excellent presentations today. I have left the evaluation link in the chat box for everybody. We don't have grand rounds next week in lieu of the American Academy meeting, so we'll see you guys back in 2 weeks' time. Enjoy your weekend, everyone.